Thank you very much. So Zika virus, it's an enormous topic. I'm going to do my best to cover a number of different topics. I realize there are people here from very different backgrounds who are looking for different things from this talk, and I'm going to try to cover a little bit of everything to meet that. But before I do that, I want to say I have no disclosures. And I wanted to show you kind of what this is all about. Stat News made a video of a one-year-old child with microcephaly. It came out about 6 months ago in Brazil. This shows you the impact that it has on these families and how one child can, what that does to a family, what that can do to a community, and then you can multiply by thousands and thousands that they have in Brazil right now. For those of you that don't have children, a one-year-old child, many of them are walking or they're about to walk. Many of them are babbling. And for the parents of young children, you can see a little bit more the milestones that this child has lost.
Ontem aconteceu um sonho da minha princesa. Fez aninho de vida. Muitos anos de vida. Eu entrei em desespero, porque eu não sabia o que era microcefalia, eu não sabia o que fazer. Pensei que eu não ia ter mais vida, pensei que minha filha ia sofrer muito, que ela havia no mundo para sofrer. Ela foi planejada, foi sonhada, desejada, porque que Deus estava fazendo isso com a gente.
Vou abrir, mamãe. Pode sair? Quer sair?
Logo no início eu imaginava muita coisa, de ela não responder aos estímulos, entendeu? De ela não aprender nada. Mas eu vejo que é diferente, ela aprende. A gente ensina, repete, até ela aprender, ela vai e aprende.
Aninho.
The brain plasticity in the immature brain is much higher. That's why kids can really compensate some functions. Of course, there is a limit.
A mão da Sofia tá bem abertinha já, né?
What we know is that some kids have much more access to rehabilitation programs and stimulus than others. If you start earlier, much better. And the frequency that you do also, it's very important.
Alecrim, tudo que nasceu. Ela melhorou muito desde que ela chegou aqui.
A gente faz o estímulo da percepção visual, porque ela também tem um pouquinho de baixa visão.
Vamos morder? Morde mais. Vamos trabalhar essa mastigação, Sofia.
Parabéns pra você. A mamãe ensinou direitinho, hein? As palmas.
A gente procura viver um dia de cada vez, porque a gente não sabe como é que vai ser amanhã. Hoje ela tá bem, amanhã a gente já não sabe.
That story is very real to me. It's just as real to me as when I was speaking last week with a sonographer in Trinidad, and they had an epidemic that came through. The sonographer did 800 ultrasounds during that epidemic, and the microcephaly cases that she diagnosed, they're 7 months old now, and they have their first physical therapy appointment next year. So this child is going to benefit from intensive physical therapy and occupational therapy, but that's not the case in many parts of the world. So to back up a little bit, Zika virus became a global public health emergency declared by the World Health Organization in February of 2016. And like many of you, the first time that I heard of this virus was January of 2016, when I opened a newspaper, saw a picture of a child with microcephaly and this question of whether Zika virus might do it. At that point, there were only 50 total publications on Zika, and now there are 50 publications a week. Every Saturday, I get a little email in my inbox that summarizes or has a list of all of them, and I look through to see what's going on, what are people looking at, what's the latest, to make sure that we're kind of working in the right direction. It's no longer a global public health emergency, but the World Health Organization considers it it's not an emergency, but it's escalated in importance. It's a significant and enduring public health challenge that will continue to be a long-term focus of WHO. Zika is here to stay, and WHO's response is also here to stay in a very robust manner. There are 48 countries with active local Zika transmission right now, and more than 3,000 cases of confirmed microcephaly in Brazil alone. Many of the other countries don't have a really good way to report microcephaly. The definitions have changed somewhat. It's very difficult to get a read on what's going on in many other countries. So when we back to January and February of 2016, people would ask me, can a virus even do this? Can a virus cause microcephaly? This is absolutely a no-brainer to obstetricians and gynecologists and pediatricians. We know they can do it. Parasites can also do it. And the ones that I've outlined here in red are ones that are particularly good at it. But Zika virus is sort of in a class by itself because it's such a silent disease. It's one that we don't have a vaccine for, and it came out of nowhere and affected very large populations. So Zika was first discovered and isolated in 1947 from a rhesus monkey from the Zika forest in Uganda, where it gets its name. It's transmitted by the bite of an Aedes aegypti mosquito, also called the yellow fever mosquito. That's actually quite prevalent in the Gulf Coast of the United States and in South America, Latin America, the Caribbean. It's a flavivirus, which means it's related to dengue, yellow fever, chikungunya, in that same class, Japanese encephalitis viruses. Zika virus has been isolated now from humans almost all over the world: Africa, Southeast Asia, Oceania, and then the Americas. But before 2007, it really wasn't on the map for us. Only 14 cases of Zika were documented in humans. But in 2007, there was an outbreak on Yap Island, which I won't go into today, which was very interesting and helped us to get a sense of epidemiologically what was happening. So if we look at this map, number 1 is where it was first documented in Uganda in 1947. Then it appears in 1960 in Nigeria. In the 1970s, we can see cases in Pakistan, India, Malaysia, and Indonesia. And in 2007, in Yap Island in Micronesia, or Oceania. In 2013, there's an epidemic on French Polynesia, and then sometime in 2014-15, Zika appears in northern Brazil. And it was either a world canoeing event, or the World Cup that we think brought it over there. An infected traveler boards the plane, gets off the plane, a mosquito bites that infected traveler, and then bites someone else, and so the disease spreads. And many of us became interested when we saw this surge in cases of microcephaly in Brazil. I think in the beginning there were more than 4,000 cases reported in tandem with the Zika outbreak, and the Zika virus was quickly isolated from the amniotic fluid and the placenta. But was this happenstance, or was this causative? There was quite an interesting cluster of microcephaly cases in 3 northeastern states of Brazil, and so there's a lot of conspiracy theories ongoing. Could this be environmental toxins? They're spraying, crops. Are these GMO mosquitoes? What else could this be? Does it have to be a virus? And then this kind of took our breath away. This was published, I think, in January, February of 2016, rapidly after kind of the world became aware of this. This is a case report. This was a woman from Slovenia who had decided to become a caseworker in Brazil, an aid worker, essentially go to help. She didn't realize she was pregnant, went to Brazil, realized she was pregnant, developed a fever at the end of her first trimester, moved home to Slovenia, had 2 ultrasounds that looked normal. Then at 29 to 32 weeks, I think we can imagine probably her fundal height fell off. She had an ultrasound for growth, and at that point, the brain was less than the second percentile. There was fluid in the brain, and the brain structures looked blurred. And that's not something I've ever seen on an ultrasound report here in the United States, or something that anyone's told me before. So this was clearly a very, very serious defect. And they found Zika virus genome in that fetal brain. Let me go back and tell you what was happening in February of 2016. In the first few weeks, I was sitting in the office of one of the world experts of microcephaly, just downtown at Seattle Children's Research Institute. And I asked him, I said, what is this? And he said, well, I'll tell you what it's not. It's not microcephaly, because microcephaly, as we understand it, looks something like this. The MRI on the top is normal, and on the bottom is primary microcephaly. It's a small brain, but essentially structurally looks fairly normal. That's not what we're seeing here. Zika is a completely different animal. There's massive destruction of the brain and a failure of normal brain development. This eventually developed into something that we now call the congenital Zika virus syndrome, with malformations of how the brain cortex develops and something called the brain disruption sequence that I'll explain in a moment. Calcifications in the cortex and the subcortical white matter, massive ventriculomegaly that people who know ultrasound will recognize in this picture here, with LV standing for lateral ventricle, massive reduction in brain volume, hypoplasia of the brainstem and cerebellum, and thinning of the spinal cord and reduced ventral nerve roots. Stillbirth can occur. We don't quite know how often that occurs. Even neonatal death, if the cerebellum isn't very well formed, that can happen in the delivery room. Fetal growth restriction, eye injury is quite common, hearing loss, arthrogryposis. That's where they're born with these fixed postures and joint deformities, and that's CNS injury. So let's talk about the fetal brain disruption sequence, because this is exactly kind of what it looked like. This expert in microcephaly, Dr. Bill Dobbins, said, I've seen something like this, and in my entire career, which spans a very, very long time, I've seen it maybe between 20 and 30 times. Someone sent me CAT scans from over 20 infants in the last month from Brazil that look just like it. What happens is that the brain starts growing in fetal brain disruption sequence, and it grows for a while. And genetically, then something goes horribly awry. The brain starts to become destroyed, and the skull collapses on itself. And that's what they could see in these early MRI images. And you can see already that the shape of the brain is wrong. It's much more of a lemon shape. And then there are these stars here in D, this kind of notching that occurs. You can see it also here in the arrow. And that's indicative of skull collapse. And they would see extra folds of skin in the neck as well, because at one point the brain was larger. It was about this time that I stopped sleeping and basically tried to leverage my entire team that I've worked with for the last 10 to 15 years to focus on this and to find bridge funding and philanthropic funding to get us going in this. A few more pictures for those with ultrasound background. It can look very different between different people. You can get asymmetric ventriculomegaly. Here, one cerebral hemisphere is completely collapsed and lots of calcifications. In this case, the cerebellum is totally calcified, and that dark space where the cerebellum should be is the enlarged cisterna magna with fluid. You can see again that the shape of the skull is wrong, indicative of skull collapse. So one of the first questions that came out is, how often does this occur? What if my patient's been exposed? What do I tell her? Polynesia, that also experienced an epidemic, they didn't really know. They didn't keep track of this. But to the best of their knowledge, they thought they had maybe 8 cases of microcephaly in 270,000 pregnancies, which didn't make a lot of sense. They thought maybe their risk was 1%. Brazil had an absolute chaos going on with underreporting and overreporting, and they thought it was somewhere between 1 and 13%. But they quickly realized that fetal brain injury could occur in any trimester. It wasn't just the first trimester, but also the second and third trimesters. I think now we've settled on numbers more like 7 to 9% in the first trimester, and maybe 5 to 6% in the second and third trimester. And that's only capturing microcephaly that's diagnosed really during pregnancy or immediately as a neonate, and not long-term complications like we know can now occur, such as late onset microcephaly. So here's an example of a child that on the left, INJ, it's the same child. This was at birth. You can see there's a bit of a sloping forehead. There's something that doesn't look quite right about the skull shape, but the head circumference was normal. This was not declared microcephaly, but the brain just didn't grow after that. And in KNL, you can see the same child at 1 year of age with clear microcephaly. So this arrest in brain growth and losing standard deviations on the normal growth chart for head circumference is something that they're seeing now, in addition to the microcephalies that were diagnosed in utero. They're also seeing hydrocephalus in some infants that develops later. And we don't really know the entire picture of this at this moment. Catholic Church and Pope Francis came out right away, I think maybe it was February of 2016, and said, it's okay to use contraception. This is unprecedented. This is, we can't deal with this. You want to use contraception? We condone this. And now sexual transmission of Zika also came out. We now know that Zika virus can be transmitted in semen up to 181 days, but the majority of men can transmit it up to 45 days, which is quite long in the sexual life cycle of some men. There's sexual transmission male to female, male to male, female to male. Men should still avoid conception for 6 months after travel to an area with local Zika transmission, and women for 2 months, which has created absolute havoc in the fertility clinics. I get lots of emails about this every month. I saw this headline when I was in Sweden, so it was the summer of 2016, and it said something like, Zika thrives in the vagina. I mean, you know, can the nightmare get any worse? Zika virus can replicate in the vagina for up to 7 days, and this can be a source of infection for the fetus, because as we know, the cervix isn't very long. If you've got a virus replicating in the vagina, what's to stop it from getting into the amniotic fluid in the fetus? Not so much. In fact, you can inoculate the virus only into the vagina and replicate the congenital Zika syndrome in mice. So I think about this in a very specific way, which has to do with my research program. Dose, host factors that might exacerbate this, strain, and something that's also unique to this family of viruses called antibody-dependent enhancement. So first of all, what are all the factors that drive fetal injury? How can we model this in the laboratory so that we can test vaccines and therapeutics to end this epidemic? How many mosquito bites does someone get? What's their host inflammatory response? That can increase viremia. And in this family of viruses, when you're exposed to a related flavivirus like dengue, that might actually boost your viral load during a subsequent Zika virus infection. All of Brazil, most of South America, and in many places in the Caribbean, dengue virus is epidemic. This is endemic. You get this as a child, and you have those antibodies in place. So maybe this was part of what boosted Zika viral viremia and those cases of microcephaly. Well, maybe not. I mean, lots of travelers have gone down to these places and also gotten that too, and of course the woman in Slovenia that I spoke of before. But how does this get across the placenta? How does it get across the blood-brain barrier? What are the immune cells acting here that we can influence? And is there a difference between strains? Is the new strain different than the old strain? Or did microcephalies occur silently all along the path of this virus, and we just didn't know? The CDC activated a level 1 response for their Emergency Operations Center, which it had only done 3 times before: Hurricane Katrina, H1N1, Ebola, and then Zika. And they called it the most complicated issue that CDC had ever faced. It's a very challenging virus to fight. The response is enormously complex. If you ever tried to fight the mosquito, you know exactly how successful we have been. So the NIH came out with a number of areas of high priority for research, demonstrate cause and effect. The world wasn't convinced. How does it get transmitted to the fetus? What exactly is happening to the nervous system and the eye? What are the pregnancy outcomes? We still didn't really know. What's happening in the reproductive tract? How do we get a vaccine right now? Are there any diagnostics out there that might work? And we knew here in Seattle that we could certainly play an important role in the development of diagnostics, vaccines, and therapeutic strategies, as well as the pathogenesis piece. So I'll tell you a little bit about the work that we did, and I'll tell you about what's published, and I'll kind of refer to additional preliminary data. So in our model for studying infections in pregnancy, we study the pigtail macaque instead of looking at mice, or oftentimes in addition to looking at mice. And that's because there are a lot of differences between mouse pregnancy and human pregnancy that can be very serious when you're trying to develop vaccines and therapeutics. They have different sensitivities to pathogens. The way their placenta is constructed is different. The way they go into labor is totally different. Their drug toxicity is different, and that's built into that is a story about the thalidomide crisis, which would never have happened if you would have tested in a monkey model. And so we thought that we could look at several different pieces of this, starting with establishing a causal relationship between Zika virus and fetal brain injury in our model. And we could look specifically at how the pregnant woman's antiviral responses, her immune response, both in her, the placenta, and the fetus, might fight the virus or fail in that fight, mechanisms of fetal brain injury, and we could start testing new therapeutics and vaccines. Our first hypothesis was really very simple. We would inoculate Zika virus subcutaneously, so into the pregnant mom, similar to a mosquito bite, and that this would induce injury and arrest growth of the fetal brain. So this was truly a shot in the dark just to see what would happen. We did 5 inoculations mimicking 5 mosquito bites. We used a strain of Zika that came from Cambodia because Brazil was not sharing their strains at the time. We did a C-section and necropsy of the fetus about 40 days after we inoculated, so not so long, a little over a month. We did serial fetal ultrasound and MRI, histopathology, and then we assayed the virus in a number of sophisticated ways. And the first thing that we saw, being an obstetrician, was that something didn't quite look right on ultrasound. So on the left, you have a measure of biparietal diameter, which is the way that we measure head growth during pregnancy. And on the right, you've got a measure of femur length, which is the bone in the leg, the big long bone. And then all the different colors correspond to different standard deviations, with the mean or the average being in gray, and 2 standard deviations being above and minus 2 standard deviations being below. And what we could see is that the brain continued to grow for a while, maybe about 3 weeks, and then it kind of stopped growing. We didn't really get measurements that were much bigger, lost actually 3 standard deviations over the course of only 40 days. And in contrast, the leg bone just kept right on growing along. And so we actually came back to that in another study that I won't talk about, that Christy Walker is doing, and we actually reviewed during Husky Day. And we're going to extend that study by looking at the University of Miami so we can come up with some sort of sonographic ultrasound recommendations for how to look for fetal injury. This scan to the left, the column all the way over to the left, I remember very well, and I remember when we first saw it, because I'm not super familiar with MRI, I'm much more familiar now. But when the first images started coming up about 10 days after inoculation, the entire MRI room went silent. And I said, what's going on? What is this? And they said, it doesn't look right, especially in the posterior brain. It shouldn't be there. At this time in gestation, the ventricles should have essentially almost closed, and we've got large posterior ventricular fluid spaces. It looks like there's an injury to the brain, we kept scanning, and the way this injury developed kind of evolved over time. It got bigger on one side of the brain, and then the brain a little bit collapsed on the other side. But this was very unexpected compared to control pigtail macaques. And here, at this institution, we've got a lot of expertise in MRI, and they said, we can tell you what's gray matter, what's white matter, what's midbrain, what's cerebellum, what's fluid spaces, and we can tell you how that volume changes over time and what's actually supposed to happen. And when they did those calculations, you can see how the different colors relate to different important areas of the brain. They said things grew merrily along for a little while, about 2 weeks, a little less, and then the white matter completely stopped growing. The gray matter continued to increase a little bit, but the posterior ventricular fluid spaces that normally contract stayed big, essentially a relative ventriculomegaly. We assayed virus by a number of techniques, some a little bit coarser, which is quantitative RT-PCR, and by RNA-seq, which is a very deep sequencing method looking for rare viral reads. And I'll just kind of show you in pink. Here is the fetus that we recovered the virus from the fetal brain, the liver, and in the placenta as well. Lots of tissues from the mother, who is now 40, 50 days out from her infection. It was still in her brain, eyes, spleen, and liver. And then we said, is this exactly the same strain that we inoculated? Because this is important to fulfill Cook's postulate, where you recover the actual pathogen from the diseased organ, the same one that you inoculated. And they said, absolutely, we've got complete coverage of viral reads that span the entire Cambodian Zika virus genome. That's all that I'm going to tell you right now. I'll tell you that we've spent the last year validating these results, and they are validated in a larger study. They are under review right now for another journal. We have the next series of experiments planned, and we're working on funding. We've got lots of grants pending. We have at least one vaccine that we want to start testing right now, possibly a second vaccine, and we're looking hard at other therapeutics as well. I'll come back and tell that story maybe next year when some more things are published, but that's all that I can say right now. So how do we care for these pregnancies? We're obstetricians at heart. What do we do for them? What can we do? First of all, the clinical symptoms can be really challenging. So a lot of people are asymptomatic. Maybe only 20% of people are actually symptomatic. That might be a little higher in pregnancy. But what you're looking for is a rash, fever, joint pain, pink eye, myalgias, headache, vomiting. All of these things are very nonspecific. And in these parts of the world where the epidemic occurred, this can be anything. It can be dengue, it could be chikungunya, it could be mayuro, it could be, you name it. There are a lot of lookalikes. And are you going to be doing expensive testing to figure it out each time? No, you don't have the resources. That's not actually cost effective. So you end up having a situation, an environment where new epidemics can come, and it's very difficult to sort out what's actually going on. In fact, just the viral syndrome of Zika looks incredibly similar to dengue, not quite as bad, and also looks similar to chikungunya. Chikungunya actually is more symptomatic. Zika was less so. And that's why it was really so incredible that these physicians on Yap Island in 2007 called the CDC and said, we're seeing something totally different from these other two syndromes. They deserve a lot of credit in putting Zika on the map for us. So if you are taking care of pregnant women and they say, I want to travel to blah, 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 you go to the cdc.gov Zika webpage, and there's an areas with risk of Zika. And you can see here in purple which areas have active transmission of Zika. Texas and Florida, the travel advisories were lifted just in August and in June, very recently. But now with the hurricanes, who knows? We start the whole rodeo once again. In Southeast Asia, you can see it's a very, very large swath of Southeast Asia that also has active Zika transmission. So, in a sense, it's almost half the world. where there's concern for Zika in pregnancies. Something really interesting has happened to the epidemic, and this is both good for the world, but also bad in terms of maintaining the heightened level of interest that we need to fight these epidemics and to also attack Zika, which still represents a very devastating infection in pregnancy. So this is the number of cases on the y-axis, and this is epidemiological week, and this is how the Pan American Health Organization, which is the regional office for the WHO, kind of monitors things. So 2016, you can see early on they had a very big epidemic. And then in 2017, it's much, much smaller, but you can see the axis is so tall that it's still about 1,000 cases per week. But there are many regions of the world where the epidemic is only now kind of starting to peak that didn't have such a big epidemic last year. So it's wrong to say that the epidemic is declining everywhere. There's still quite a few hotspots that people should know about, especially when you're counseling pregnant women. So Bolivia is one of those where the infection number of cases seems to be rising. Same is true in Belize. And then the Bahamas, I throw this up there because I find this so interesting. So the Bahamas, you can see kind of what they reported, both suspected and some confirmed cases, and then it totally falls off the map. There's zero. There's like absolutely nothing in 2017. And I love these kind of data things where you look at that and say, So this is from the Bahamas.com website. Bahamas remains Zika-free. I just took this off their webpage yesterday. There have been no reported cases of the mosquito-borne virus in any islands of the Bahamas. You can imagine the tourism dollars that are connected with these epidemics and how important it is for them to have out there this marketing approach that they are Zika-free. Fortunately, we have had no locally acquired cases in the US in 2017, so these advisories for Miami-Dade County that created a complete nightmare for the OBGYNs that were there, and the 50 to 70,000 pregnancies that are in Miami-Dade County at any one point in time, and also the Rio Grande Valley. So no reported cases in 2017, but then we have had a few hurricanes. What happens after hurricanes is standing water. The mosquitoes get swept away in the first 10 to 14 days, and then the breeding gets going. And then there ends up being a mosquito explosion. The US Air Force, although we haven't given really aid to Puerto Rico, the Air Force is flying cargo planes spraying insecticide over 600,000 acres in Texas. I don't know what they're doing exactly in Florida, but this changes very much the whole climate of mosquitoes and mosquito-transmitted viruses and the epidemic. So we'll have to look in on it next year, kind of in retrospect, to figure out what's going to happen now. I think we're still very, very much in the woods. And the reason is that we have so much air travel between these countries with ongoing epidemics. We've got standing water over a good chunk of these areas now with active local Zika transmission. And we here in the United States, we're Zika naive. We don't have large populations with herd immunity that have been exposed to it before, so we really remain at risk and will remain at risk as long as these epidemics are occurring in different parts of the world. And I'll go into that more at the very end. So what do you do for Zika virus testing? You're going to go to the cdc.gov website, download forms, 10 pages of paperwork. You're going to do it upside down, 3 types of tubes from the patient, lock of hair from the nurse, sacrifice a virgin, get the patient's autobiography on the tube with a special pen. If the lab doesn't get it, it's just going to throw it away. Your firstborn child will be obtained by authorities and you will go blind. We have all been here. It's incredibly painful. The recommendations have changed every few months. I'm now on the Zika expert work group that helps to inform CDC on these recommendations. This is what we are supposed to be referencing. July 24th, 2017, it came out. I think I probably read this document 9 to 10 times to really kind of understand what it was saying and what was driving it. And even in this document, they know already that within 6 months, we'll probably have new guidance. And the reason for the new guidance is that the overall global prevalence in these parts of the world that are affecting the US, the prevalence of Zika virus infections is declining. That changes sensitivity and specificity and all of those things with testing. We now find that we can detect IgM from Zika virus way beyond 12 weeks. That creates all kinds of problems in understanding whether it's an acute infection or an old infection. So that leads to this increased number of false positive tests when you're looking for infections specifically in pregnancy. So if a woman is symptomatic, she comes back, she says, I've had the rash, I've had the pink eye, I'm one of those people. Or you do an ultrasound on someone who traveled there, and you see something that looks like congenital Zika virus syndrome, you happen upon it, you get PCR blood and urine, and you get the IgM, and if it's positive, then you get the plaque reduction neutralization test, the PRINT confirmation. If you're beyond 12 weeks, you'll probably only get the IgM with PRINT confirmation, because now we know the IgM can still be there for 5 months, maybe even 6 months out. If the woman is asymptomatic, but she's traveling back and forth, or her partner is traveling back and forth to these areas, which is very common in Texas and Florida, you're going to just try PCR, urine, and blood 3 times during pregnancy. And you can choose whenever you want to do that, because we have no idea how, what to recommend and how quickly to recommend that after travel. If she's asymptomatic and she's had possible exposure, and I think we've all had patients that have traveled to Miami or Asia, they were there for 48 hours, they stayed in the hotel the whole time, we no longer routinely recommend testing. But if testing is done, you're going to do the PCR, the IgM with PRINT confirmation. ACOG wanted CDC to have a way out so that obstetricians who are just burdened by these recommendations in Florida and Texas could say, we don't need to test everyone. We need to actually have a shared decision-making model where the obstetrician and the patient decide together, what's her risk? How worried is she? We know there are IgM false positives. What about her travel history? Did she use repellent? Where did she go? What does the epidemic look like exactly where she was? So now it's a little bit more up to you and the patient, and the burden is a little bit more on you to kind of come up with a nuanced discussion, which can be very difficult when you're not living this literature all the time. So how to interpret Zika virus testing? This is also not straightforward. You've got 8 possible combinations of results, and many of them don't really give you a lot of uncertainty. I love this one, flavivirus infection. Specific virus cannot be identified. Timing of infection cannot be identified, can't be determined. That pregnant woman is like asking you for answers who's already worried about her pregnancy, and you don't know what to say. Is it dengue? Is it, what is it? When did it happen? So this also creates uncertainty, and this is what builds into all of these CDC reports where it talks about, cohort of birth defects in women with possible Zika virus infection, because they're lumping in women together with these uncertain diagnostics. So good news and bad news on the vaccine front. More than 30 Zika virus vaccines are in development. I know 4 investigators that have Zika virus vaccines. There was a lot of information about how to make such a vaccine. A lot of people copied what had been done for dengue virus. The NIH kind of stood behind a DNA-based vaccine approach, which is fast and easy to make, but may not be very potent. And then now, with kind of the declining epidemic and possibly with change in administration, politics and funding are kind of rewriting what's going on with this, and there's going to be some changes in things. And I'll talk about that in a moment. But challenges for vaccine development here are huge. When you've got a global perception that only pregnant women and fetuses are at risk, that's an immediate problem, because around the world, not many people care about that. A Zika virus vaccine could possibly cause Guillain-Barré syndrome, something that they see in adults. That's got a 10% mortality if you're not near a hospital with a ventilator. So think about that in these large parts of the Americas and the Caribbean, and going ahead and vaccinating a whole population. So what's instead developed is that we'll have population-specific recommendations for different vaccines. Again, very complicated, complicates things. Next problem is that there could be cross-reaction in some individuals between the immune response to dengue and Zika viruses. So a Zika virus vaccinated individual could become ill or die with a subsequent dengue viral infection. That might have happened anyway, but maybe the vaccine helped that along. And we very much subscribe as a profession to do no harm. This is a hard one to deal with and not one that we can really model well in the laboratory. So again, this is one of these where you can vaccinate people that live in different populations in a different way, possibly with a nuanced discussion, and then you roll it out and see what happens. And then you revise your recommendations. There's really no other good way to test it. And what's the vaccine demand going to be if there's an epidemic in decline in many countries? And I work with a couple of different pharma companies related to preterm birth therapeutics. They want a therapeutic or a vaccine with a $2 billion market, or they are not interested. And that is a huge challenge. So this kind of quietly happened a few weeks ago. Sanofi pulled out of their Zika vaccine collaboration with the feds, which had to do with politics and how that vaccine would eventually be licensed. Sanofi was taking money from the US Army and US government, but they wanted the exclusive license. Pharmaceuticals are on the hook in many, many ways for this. I don't know that that's going to go that way with any other pharmaceutical. The Department of Health and Human Services had committed quite a lot of money for this. They said there's no money. Sanofi said we're not developing the vaccine. There's one gone. And so I think that will be the way that a lot of these different vaccines will go, and we'll have to see which pharma company is left standing in this fight at the very end and what those vaccines look like. But something very interesting has happened very recently, and that was a working group of experts for vaccines in maternal and fetal health that got together. They were funded by the Wellcome group by the UK to develop a best practices document on pregnant women and the Zika virus vaccine research agenda. And they said, this is what's important. If you're going to make a vaccine, let's tell you what's important. Oh, that's interesting. That kind of disappeared. They said, pregnant women must be a part of clinical trials, and they are a priority group for development of your vaccines. A lot of vaccines are using things that are very powerful and very potent, but they're in a measles vector. We're just not going to give that to pregnant women. We want those vaccines to be developed that are going to go to pregnant women. They need to be part of the trial. Their needs and their wants need to be a part of this discussion, which immediately changed what we were doing in our program, and I think will help to change the climate all around. So I hadn't heard of Zika virus until January of 2016. I think many people in the room hadn't either. And so to prevent you all from being off guard, let me introduce you to the list that the World Health Organization has of viruses with epidemic potential and no or inadequate countermeasures, and how this might relate to subsequent epidemics, especially in pregnant women, and what we might see going forward. So on this, we've got Lassa fever, many people have heard, but Crimean Congo hemorrhagic fever, MERS, SARS, Nipah, Rift Valley fever, severe fever with thrombocytopenia syndrome in rural China, Zika virus, and then they have a new category called Disease X, because, there's stuff that we don't even know yet. And I put in that category chikungunya and Mayoro viruses, which are now circulating very prevalently in northeastern Brazil. It's almost like a repeat of what was happening in 2015 with Zika virus. And they don't have influenza, yellow fever, and cholera on the list because countermeasures exist for those. So now if we take it one step further and say which of these are neuroinvasive, RNA neuroinvasive viruses, that might on paper do something bad to a pregnancy and might invade the fetus? Well, that's pretty much almost all of them. So this came into my inbox yesterday, and I thought, oh, I have to show this to everyone. Because this is so classic. You know, we've got all kinds of small epidemics waiting to kind of, you know, become something big. The second one is the second diagnosis of fatal human case of St. Louis encephalitis virus infection. This is a mosquito-transmitted virus in a 68-year-old man sitting on his porch in Bakersfield, California. Neuroinvasive virus that causes encephalitis. Big dengue virus outbreak right now in Argentina. Dengue virus went from Cote d'Ivoire to Japan in June of 2017. Again, air travel we have to thank for a lot of these spread of these things. But chikungunya virus is being watched very, very closely now, and this has much more, has many more symptoms, and people are much more debilitated by this than Zika. It can cause really debilitating joint pain for months after the original infection. Many more people are symptomatic. Also a neuroinvasive virus. And now it's circulating prevalently in northeast Brazil. An enormous team has worked with me very tirelessly since we got this program together, and I have so many people to thank. I'm going to mention a few people. Lakshmi Rajagopal at Seattle Children's has been my long-term partner in studying Group B streptococcus, and she leveraged her entire team to work on all these Zika virus experiments with me. The Center for Integrative Brain Research with Brandon Nelson and Bill Dobbins and were just instrumental in helping me to understand how the fetal brain develops and how we actually figure out what's going on from a pathogenesis standpoint. Colin Studholm was the efforts behind the MRI, as well as Chris Gattenby, and understanding what is going on with fetal brain MRI. Very important partner, Mike Gale at the Center for Innate Immunity and Immune Disease, who has a very large program studying flaviviruses, who leveraged a large portion of his team to study this. Jennifer Stencil-Barenwald, Jenny Tasanchik-Go, Justin Roby, Michael Davis, among others. And the Washington Primate Center, who has always stepped up for new research and vaccines and therapeutic development and understanding infectious disease pathogenesis. Jason Ogle, Chris English, Audrey Baldessari, Audrey Gurmand, Richard Grant, Lorene Cooler, just to name a few. It's a very large team. I think that I talk to about 80% of the team on a weekly basis, and I meet with maybe half the team as well. So it's a very large collaboration, and there's a lot of research coming out with it. And in the process, we've developed not only the collaborations, but the friendships and the working culture to work together on not just this virus, but the next one and the next one. So thank you very much. The question is, why is there a difference in the microcephaly rates between some parts of the world and other parts of the world? And embedded in that question is the assumption that there's good pregnancy care, there's good ultrasound practice, and that women are being monitored and that maternal fetal outcomes are being tracked. And that's not the case. Columbia swore up and down that they had no microcephalies, nothing was going on. Same month, I was at a conference in Sweden and gave a talk on Zika virus, and a Colombian physician said, come over here. took out his iPhone and started scrolling through, showed me 10 microcephalies. I'm like, what's going on? They're saying that there are none. What's happening? So I can't explain why some governments report things, why some governments do not report things, why pregnancy care shouldn't be, shouldn't honor a pregnant woman and, her unborn fetus. I can't explain these things. What we've learned is that in most cohorts, no matter what we do, it's somewhere between a 5 and a 9% risk of microcephaly immediately during the pregnancy or immediately neonatally. We don't yet know this late onset microcephaly phenotype because the children are very old, how many of these develop microcephaly later. And we don't really have a good handle on how many have ocular defects, which seems to be quite high at the University of Miami in their cohort, or fetal brain development. So microcephaly is one outcome. It's a coarse outcome. It doesn't mean that there wasn't damage and that the immune response to some degree didn't attack the virus and control it to some degree. And sometimes the placenta, I think, can resolve infections. I think that Zika works very efficiently to impair the host immune response, and Mike Gale's lab is working to understand exactly how that occurs. But, again, when you're talking about low resource settings and low and middle income countries, and then you want them to report maternal fetal outcomes, that can be a real challenge for them. And it's no longer news. If there's a microcephaly associated with Zika virus, it's certainly not news anymore.
The visual impairment really just magnifies the microcephaly issue. Is there also impairment of hearing?
Yes, there's also impairment of hearing, and so there's recommendations about both auditory screening and eye screening as well, similar to rubella and cytomegalovirus and other viruses that we're more familiar with that cause birth defects.
Talk about the need to include pregnant women in vaccine trials. So is there any effort for vaccines, not a prevention, but in terms of decreasing transmission, and also are there any efforts looking at therapeutics in terms of treating patients that are already infected and decrease transmission?
The question is, what's happening to women who have already been exposed or infected? Can we give them therapeutics? Can we give a vaccine to boost their immune response? What can we do once they've already been exposed? Pretty challenging. So in our model, we saw fetal brain injury 10 days after inoculation. And most women are not symptomatic until maybe 10 days to 2 weeks after their initial exposure. So there's this period of time where the virus replicates, but people may or may not be symptomatic. And that's really the window where you need to act. So the question is, can we give a prophylactic to people that are traveling to try to prevent viremia that may not be vaccinated yet? And there are several good candidates that seem to control Zika virus replication, at least in vitro, and I think in at least one mouse model.
Do you have any information on the life history of the virus in the mosquito?
Question is about life history of the virus in the mosquito. I've kind of left that to my mosquito collaborator, Dr. Kathy Hanley at the University of New Mexico. That's a whole science in and of itself. And keeping up with the pregnancy side of things, the pathogenesis side of things, and the vaccines and therapeutics has been a huge challenge. But if you've never been to an insectary where they grow mosquitoes and they do this type of research, it's incredibly interesting. It's like walking into a swamp and you see, it's very damp and, humid, and then they can dissect out the salivary glands on lots of mosquitoes with a microscope. It's very interesting. But no, I'd ask a different expert about that.
So I know we relied on the numbers 2 months and 6 months for men and women as far as transmission time after they've been exposed. Do you feel like we have solid research to support that recommendation since we are using it so broadly?
I think that we got a little bit better information on the, how long it persists in semen, and that's, I think, was published maybe last month in the New England Journal. Again, we're talking about 20 individuals. And in those 20 individuals, I think in 60, 70%, it persisted between 30 and 45 days. But there are certainly, going to be outliers in an entire population. So we don't have very good information. We know it can be detected up to 6 months, but we really just don't know. Steve.
Are women who are previously infected with Zika protected from reinfection, like in a specific time or during pregnancy by the antibody response? Or is it more like
The question is whether a woman who's been infected and has presumably IgM, IgG antibodies, is she protected in subsequent pregnancy? We think so. Okay, thank you so much.